Adesso abbiamo la nostra keynote, introdurrò in inglese il relatore a momenti, ricordandovi che al termine della lettura magistrale ci sarà un piccolo aperitivo offerto nei saloni del rettorato. So I'll introduce and I'll switch to English Professor Corina Benjet. Corina is a senior researcher at the Instituto Nacional de Psiquiatría Ramón de la Fuente Muñiz in Ciudad de Mexico, and she's a professor in the School of Medicine and Psychology at the University Autónoma of Mexico, UNAM. And she is the coordinator of the graduate course in public mental health. She holds a PhD in psychology from the National University of Mexico, and a master in clinical psychology. She's here as a representative of the World Mental Health Survey initiatives, and we are very glad that you are here with us. Your research interests include mental health epidemiology, mental disorders with particular reference to adolescents and younger populations, and the use of precision medicine and digital strategies to promote mental health in this target population. Corina, it's a great pleasure to host you here in Italy. The floor is yours. Thank you very much for being here.
Can I open this? Sure. Grazie. Buonasera. That's about as much as I can speak in Italian. Sorry about that. I'll try to speak slowly. Oh, great. Thank you. So you can understand, but I do have a tendency to speak quickly. But I also really would like to thank Professor Odone for this wonderful invitation. And also I want to congratulate all of you for this very important initiative. From what I've been able to understand in these last few presentations, I didn't understand a lot, but I am impressed by the very integral approach that you're taking, sort of out of the box thinking in terms of all the possible strategies that we can use to help university students, including, I believe I understood, through sports, music, digital app, and yoga, and all kinds of things. So I really applaud that effort. So I'm going to divide my presentation today into two parts. Let's see, how do I do this? The top one? No. There we go. Oh, no, how do I go back? Well, I don't know how to go back, but I'm going to do it in two parts. So the first part, I'm going to talk about the World Mental Health College Student Surveys, basically the prevalence and the treatment, that very important treatment gap that we have in university students around the world. And then I want to take the second part of the presentation to talk to you a bit more about how are we addressing these problems. So using digital mental health interventions and precision medicine to reduce this treatment gap in a program that we're doing in Colombia and Mexico called Yo Puedo Sentirme Bien. And then I'll end up by talking about what's next for World Mental Health and the World Mental Health College Student Surveys. Okay, so these are the surveys that we've done to date. The college initiative began in 2014. The first country was Belgium. Mexico started in 2016. And in the first 3 years, we did about 22,000 baseline surveys. This was using the DSM-4 categorization in 9 countries and in 33 universities. In 2017, around then, we switched to the DSM-5 version. We came up to 16 countries, 72 universities, and we now have almost 100,000 baseline surveys. We also have follow-up surveys of many of these students. And I put this QR code of this journal here because this journal, the entire number, is dedicated to the World Mental Health College Student Surveys initiative, and all the data from the very first countries are published there. Just to give you a very quick overview of the methodology, I presume you know much of it since you're doing it here. But this is a design that is a 4-year longitudinal perspective study. So we do a baseline survey of incoming first-year students, and we evaluate them every 12 months for the 4 years. So we get most of their college education. The instrument that we're using, I believe, is the same instrument that you're using. The important thing to note here is, though I'm only going to show you data today about mental disorders, this instrument is a lot more than just mental disorders. It has all kinds of things like chronic childhood adversities, stressors, bullying, peer relationships, physical exercise, etc. We get IRB approval for each country. Students give online informed consent. It's very important, although we try to get as many students or all students to participate, it is voluntary, but we do have some strategies that we use, like trying to link the survey to sort of obligatory activities of first-year students, or if they have to do professor reviews, when they have to do the professor reviews, they also see the link, or sometimes on the registration pages to register for classes, we put the link. So we try to do it as much as possible to sort of obligatory activities that all students have to do. We do find that the first-year students are fairly good about answering. After that, they sort of realize that they don't have to do what the university asks them, and the response rates are a lot lower for the older students. And when we identify students with any kind of mental health problem, we refer them to services. At least this was our strategy in the first years of World Mental Health before we went on to the intervention aspect. So this is the lifetime prevalence and age of onset of common mental disorders. These were the first countries to participate using the DSM-4 version. And as you can see, overall, the mean was 35.3% of all incoming students met the criteria at some point for some common mental disorder. So you can see the prevalences vary quite a bit by country, but what is remarkably similar over every country is the age of onset. These are problems that are starting at 14 years of age. So these are not new problems. By the time students get to university, these problems have been around for a long time. We do see in the longitudinal data new onset of disorders, but that's much less than what we're seeing when students begin university. When we look at specific types of disorders, the most frequent disorders are depression and generalized anxiety. And that's why the second half of this presentation, when I talk to you about digital mental health interventions, we're targeting them to depression and anxiety. And we can also see that 12-month prevalence and lifetime prevalence is very similar. So these are very chronic disorders, very persistent disorders. Now, this is the data. I should mention that the data I showed you before, which was from the DSM-4, was also pre-pandemic. So we had, after the pandemic, we started using the DSM-5, which is a little bit unfortunate in the sense that it's hard to know what this huge jump in prevalence is due to our changing to DSM-5. We did add a few new disorders or the pandemic. But as you can see before, we had about 1 in 3 students were arriving to university with some common mental disorder across the globe. And in this new data from 2017 to 24, we have now almost 2 out of every 3 students are arriving to university with some mental disorder. Unfortunately, the amount of students that receive treatment is quite low. So this is also the average over all of the countries. For any lifetime disorder, 36% of students at any point in time have received treatment for those disorders. And for students who have had a disorder in the last 12 months, only a quarter of them have received treatment in the last 12 months. So really the majority of the students are not receiving treatment. And this is the average over all countries, but even the countries that have the most, the best, they put the most money into mental health services, still the majority of their students are not receiving mental health services. This is the rates for suicidal ideation and behavior. So you can see almost a third of students have lifetime suicidal ideation. 17% have a lifetime plan and 4.3% have a lifetime attempt. This is also fairly consistent over countries. Again, the age of onset is between 14 and 15 years of age, so these are not new problems. So what are the barriers to seeking? We asked these students, of all the students who report symptoms, why did they not look for treatment? And these are the reasons that students give us. The number one reason, and this is pretty much across all countries, the first reason they give us is they want to deal with their problems on their own. Not quite clear what this means, if it's a combination of stigma and other things, but they want to deal with the problem on their own. That's 56% of students with problems tell us that. They prefer social support, in other words, talking to their families or friends than to talking to a health professional. 33% of them feel embarrassment. 30% don't know where to go. That's probably the easiest thing for us to solve, is just making that information available. That they think it's too expensive. They're not sure of the effectiveness of treatment, afraid of harm to their career if anybody should find out that they're in treatment. Problems with time, place, or transportation, 22%. And we also have another other category, which in Mexico, a lot of what the students put is, I don't want my parents to find out, or my parents don't believe in therapy. So now I want to talk to you about the next stage of this, which is actually getting interventions to these students. So the first part is identifying what the problem is. And after we spent several years identifying the problem, we felt it was important to really take action and try to take a more public health approach. There's no way that universities, at least in Latin America, I don't know here, but I assume it's very less similar. Universities' mission is to educate, it's not to provide mental health services. And if 1 out of 3, or even now 2 out of 3 students have mental health problems, thinking that we're going to be able to give them face-to-face, one-on-one psychotherapy and medication is just not realistic. It's never going to happen. So we really need to start thinking about approaches where we can have scalable interventions that have a huge reach, and we can save those in-person, one-on-one interventions for the students who really need them and can't benefit from any other type of treatment. So this program I'm going to tell you about is called Yo Puedo Sentirme Bien, or I Can Feel Good. We're doing this in 8 different universities across Colombia and Mexico. And I want to mention my collaborators because I'm sure as most of you have found out during this project, these projects take a lot of people, a lot of effort, and a lot of passion from a lot of people. So all these names here, there's probably even more people behind each one of these names. But I want to, and particularly thank Dr. Ronald Kessler, who's part of the reason why I'm here today. So the question we wanted to ask in this new phase of the project is, can we decrease the unmet need for treatment of depression and anxiety in university students and increase the effectiveness of treatments through inexpensive, scalable, internet-based cognitive behavioral therapy interventions by creating precision treatment algorithms that can predict for whom ICBT is most effective? So the objective was to use machine learning to develop individualized treatment rule, which would tell us for each individual student which would be their optimal treatment based on a large set of baseline predictors. So just to mention very briefly, in case for those of you who don't know what precision medicine is, it's this idea that not all treatments work for all people. And it takes into account individual differences. Those differences might be genetic, that might be environmental, that might be lifestyle, that makes some people respond better to certain treatments than others. And we use machine learning with very large data sets to generate algorithms which can tell us which treatments work best for whom, and assign patients to their optimal treatment at the lowest cost. So just to give you a quick overview of the study, we've actually done 3 randomized controlled trials of guided and self-guided transdiagnostic ICBT and treatment as usual. Our first 2 trials, we had these 3 arms. In the final trial, which I'll tell you about, we only had 2 arms. The main inclusion criteria were students who had anxiety or depression, and this was classified as having a score of 10 or more on these 2 instruments, the GAD-7 and the PHQ-9. They had to be 18 years of age. We eliminated students with imminent suicide risk. I actually regret that now. In hindsight, I would have done it differently. In all of our new projects, we're going to do that differently. And a history of psychosis or bipolar disorder. And we had 3 different recruitment strategies because we were really looking to try to get to 3 different types of students, well, 2 different types of students, really. So one recruitment strategy were students seeking attention and on a wait list at university clinics. Not all of our universities had formal clinics, but the universities that did have formal clinics, they tended to have very long wait lists that could be months long. So we wanted to be able to see if we could give tools to students who are on the wait list. Could they get better before they even got to their appointment? And then they might not even need their appointment. Because we also know that students, when they're on a very long wait list, they never show up to that appointment when it's a couple of months later. But these were students who recognized they had a problem and were actively looking for help. And then the other strategy we used was to send email invitations to representative samples of students. We sent about 1,000 email invitations a week, just out of the blue. And we would tell students, we know this is had been a very difficult time. If you're feeling down, anxious, we might have something for you. And students would answer to that. And this is a very different type of student because this is a student who doesn't necessarily know or recognize that they have problems, or they're not willing or haven't actively tried to look for help. But they might, when they receive this, pique their interest and get some help that way. And then we also, of course, use campus social media campaigns. That was actually the least successful of all of our recruitment strategies. So the intervention we used was a cultural adaptation of an intervention that was developed by Silver Cloud Health in the UK. That's actually a platform that's used in the health services in UK. There was an original adaptation for Colombia, and we took that and did a further adaptation for Mexico. It's developed to be an 8-week cognitive behavioral therapy program with 7 modules and several additional modules. And it has 2 different modalities, a guided modality and a self-guided modality. People in all modalities have access to the platform for 12 months. But those who have the guided version, for 8 weeks, they have a guide who once a week gives them asynchronous written feedback. And the people who have the unguided version, they have exactly all the same content, the same materials, but they just don't have this guide for 8 weeks. And then treatment as usual, which in every university was different. Some universities had formal clinics, other universities had informal counseling through their psychology department, and other universities just referred students off campus. So cognitive behavioral therapy, for those of you who might not know, is a structured and goal-oriented therapy. It's decades and decades of research that shows that it is efficacious for the treatment of anxiety, depression, and stress. And basically the idea behind CBT is that there's an interaction between emotions, behaviors, and thoughts. And if we can change behaviors or thoughts, then we can change mood. So how is CBT online from face-to-face CBT? CBT online uses all the same techniques that face-to-face CBT uses. We're not talking here about telemedicine. All of this is asynchronous, and really it's the materials, the exercises, the videos, that's the therapy, not the therapist. It has the added advantage that face-to-face treatment doesn't have, of that the students can do this 24 hours a day, 365 days a week. They can do it sitting on their bed. They can do it on the bus on the way to the university. Anywhere they have any kind of internet connection, they can do this at any time. There's no wait list, so they have immediate access. We feel that it gives them a greater sense of control. If you recall, I had said that the number one reason for not looking for help was that they want to deal with their problems on their own. Well, this is a way to give them something, a tool where they can feel like they're dealing with their problems on their own. And it's confidential, so all the students who don't seek services because of stigma, worry that somebody would find out, well, nobody has to find out. Nobody sees them go into the mental health clinic, and there's no wait time for an appointment. So what is CBT? Well, it has 2 main strategies. One strategy is called behavioral activation, and that's basically encouraging the users to find activities that are either pleasurable for them or give their life meaning, and to engage in those activities, but not waiting until they feel motivated to do it. The motivation will never come before the activity. They have to do the activity first in order to be in the mood to do the activity. And we have several activities in the platform to engage them in doing these activities. And the other great main strategy of CBT is cognitive restructuring. This is where we help the students identify their usual way of thinking, that sort of internal dialogue that we all have within us, and how that way of thinking affects their mood, their anxiety, and their depression. And we help them develop abilities to find these patterns of distorted thoughts and change them and substitute them for more realistic or more balanced thoughts. And so these are all the activities that we have in the platform to help them with those activities. So these are the different modules in the platform. The first 7 of them, everybody has access to. If they're in the guided program, their guide will open the different modules as they see fit. If they're in the self-guided program, they see all the modules from the beginning, but everybody by the end gets all of the modules. So as I mentioned, we have the people do this online survey, and then they're randomly assigned to one of these 3 interventions, the self-guided intervention, the guided intervention, or treatment as usual. And the outcomes that we're looking at here are 3-month and 12-month joint remission for anxiety and depression. That means they have scores of 0 to 4 on both the depression and the anxiety scale. And we also look at the change in mean scores. So we have a very, very large predictor set. Some of you may wonder why these surveys are so long. This is the reason the surveys are so long, because we need rich information in order to develop these machine learning algorithms. So we ask about socio-demographic variables, university-related factors, stressors related to COVID, because we began during the pandemic, other recent and lifetime stressors, like bullying, for example, characteristics of anxiety and depression, like how severe it is, what their age of onset was, comorbid medical disorders. So if they have PTSD, they have a problem with alcohol or drugs, social phobia, etc. The type of mental health treatment they've had, physical health problems, social networks and supports that they have, different characteristics of their personality and temperament, psychological resilience, also information on internet literacy and their preferences for looking for help on the internet. And this is 284 different predictors that we use in our models. So this is the participant flow of all three of our trials. We were able to recruit 4,200 and some students into the trial. They were randomly assigned, but in the third year, we ended up not assigning anybody to treatment as usual because nobody did better with treatment as usual. I'm sort of telling you the end of the story at the beginning. So that's why we ended up just assigning people to the guided or the self-guided intervention. And we had about a 65% response rate, both at 3 months and at 12 months. In terms of how much did the students participate or interact with the platform, it varied greatly on whether they had the guided or the self-guided version. So those who had the guided version basically logged on twice as much as the people who had the self-guided version during the 3 months. This is the data for 3 months. So the people in the guided version had a mean 11 times they logged on, and each time they logged on, it was about 16 minutes. The people in the self-guided program, they had a mean of 5 logons, and they also logged on for roughly 16, 17 minutes. These are very skewed distributions, so the median is much less. So we have a lot of people who did little and a few people who did a lot. But overall, the people in the guided program in the first 3 months did almost 3 hours on the platform, and the people in the self-guided did an hour and a half on the platform. So what did we find in terms of the impact on anxiety and depression remission at 3 months and at 12 months? So here you can see that 3 months, 50% of the students who were assigned to the guided modality had remission on both anxiety and depression. And this was significantly greater than those who were assigned to both the self-guided or treatment as usual. There was no statistically significant difference between treatment as usual and self-guided. And this sort of confirmed what we've all, at least psychologists, thought that guided is better, right, than self-guided. Because as psychologists, we like to think that we're important to the equation. But at 12 months, we had a surprise. And at 12 months, of the people who were assigned to the self-guided version, they had greater remission of anxiety and depression than the other two groups. And this was statistically significant with no differences between the other two groups. And basically what happened, let me see if I put the next. Oh yeah, so it's easier to see if we look at the mean scores. So basically at baseline, everyone starts out with 28 points on these scales. And by 3 months, the people of the guided version, they went down quicker. They had 13 points that were better off than those in the self-guided or treatment as usual. But at 12 months, what happened is the people who were in the self-guided program maintained their treatment gains, whereas the people who were in the guided version and treatment as usual started losing those treatment gains. Now, the magnitude of the difference is not that big. It's statistically significant, but the magnitude is not that important. And everybody's better off at 12 months than they were if they hadn't had the intervention, right? Let's see. Okay, I guess I didn't take out that. All right, I guess I didn't put, this is a summary of our machine learning findings. So our interest was not just which group is better than another group. Really, our interest is for whom is each modality better, for which type of student? Because we want to send as many students as we can to the cheapest, least resource intensive modality, which is the self-guided, right? So students who can benefit from that, they should definitely get that first. And we should leave students who are not going to benefit for that for the guided modality or some sort of a face-to-face treatment. So what we found out at 3 months is that if we're looking at the students who had both anxiety and depression, 90% of them did better with the guided version. And the remaining 10% had low remission probabilities across all arms. That means they need something different. What we were doing didn't work for them, but 90% it did. For those with anxiety, only anxiety, the guided modality was better for everybody. The interesting and probably the most promising finding in terms of thinking about increasing reach was for the depression subsample. So the students who had depression, 71.5% guided was optimal, but for almost 29%, self-guided was optimal. So if you think about the number of students that you have with depression, if almost a third of them, you can give them something that they can do on their own that involves no human resources once you have that, that's could have a potentially huge impact. Of course, all this has to be replicated on bigger sample sizes in more places, no? Now, some of you may be wondering then, okay, well, who was it that benefited most from the guided program versus the self-guided program? So we did our models and we looked at these values that I put here. They're called shapely values. And what they tell us is the magnitude and the direction that each individual predictor of the 284 predictors contributes to our prediction of which will be their optimal treatment. And we find that the most important predictors, let's see here, have to do with physical health, comorbid mental disorders, particularly social anxiety disorder, and PTSD, recent and lifetime stressors. Yes, those are the most important predictors of their optimal modality being the guided version. There we go. Then we want to look at, well, why was it that at 12 months, the effects seemed to invert? Why did it seem that students who had the unguided version do better at 12 months? So it occurred to us that maybe because people with the guided version only had 8 weeks of their guide. Maybe at the time we took away their guide from them, they just stopped using the platform. And the people who had the unguided version continued to use the platform. And this is basically what we saw. So in weeks 1 to 12, those who had the guided version had more number of minutes on the platform, in fact, double the minutes that people in the unguided version. But from week 13 to week 52, that was reversed. And those in the unguided program spent twice as much. Nobody spent very much time after 13 weeks. Everybody, their time went way down. But the people in the self-guided seemed to keep using it a little bit more. So then we thought, well, maybe more important than trying to predict which is their optimal treatment from the beginning, try to predict who, if we give them a self-guided intervention, will actually do it and use it and get better. So what we did was look at predictors of compliance over 12, so use of the self-guided program over 12 months. What predicted which student would do that? And we did that all from the baseline predictors, not from their actual use. And what we found is this is, again, the shapely values of the magnitude and direction that each individual predictor contributes to the prediction model. And the 3 strongest predictors were not being employed, which is thinking that these are university students having to work and study at the same time, basically means you have very little time, right? So these students who had more time available were more likely to engage in the platform over a long period of time. Students from one of our universities, the national university, that we have no idea. This is all data driven. There's no theory behind it. For some reason, the students from this university seem to use this platform much more than the other students. And students with social anxiety. Social anxiety is something that came up many times in all of our different predictions. And it looks like the students who have social anxiety using an unguided program is much less threatening for them. And so they're much more likely to keep using it than other students. So we want to then sort of see, well, if we could really verify this hypothesis. So we took our predicted values of how much people were going to comply with the program over 12 months. And we looked at the top 40% versus the 60% who are least likely to use it, and looked if we could see differences in the treatment modalities. And effectively, we did find. So students who received the self-guided modality and were predicted from baseline to actually use the self-guided modality over time were the ones who have the greatest remission on anxiety and depression. And there were no significant differences between other groups. So it really has to do with how much they engage in the platform. So the other important thing is for student engagement is how satisfied are they in general, right? So this seems like a very obvious question, but we asked students at the end of each module how much they thought this module helped my progress, was useful, relevant, or interesting to me. Obviously, this is a bit of inflated values because only students who got to the end of the module, right, who answered this. So obviously they liked it a bit. But basically 90% of the students found that they agreed very much or agreed that this was useful, relevant, and interesting to them. There was no significant differences between the guided and unguided version, although you can see by the numbers, slightly more satisfaction in the guided version. And we also have students, and this is less inflated because this is all students, regardless of whether they got to the end of their first module, how often the past 30 days they applied the things that they learned on the platform in their daily life. This is important because if you don't practice these strategies, you're not going to get better. And basically a third of the students say a few times a week, they actually practice the things that they learned on the platform. A small group of students said multiple times a day or daily, and also a small group of students said they never used any of the strategies. How much did Silver Cloud help you? Again, more or less half, a third of the students thought it was little, and the rest of them thought it helped them quite a lot, and very few students thought it didn't help them at all or it made them worse. And as an indirect method of looking at satisfaction. We asked them whether they would recommend the program to a friend, and most all of the students said they would definitely or probably recommend the platform to a friend. These are some of the messages. The students who had the guided version, when they knew it was their last week, they tended to always send a message to their guide. And these are just a few of the messages they sent. They're in Spanish, but I can translate. For example, one of them says, "There were times in my life that I had the idea of taking my life because I felt that I could just never get lower. However, receiving messages from my guide, knowing that there was somebody following me in this program, it made me feel that I was valuable to someone. Although I didn't finish the program, it helped me a lot. Even if there was just little efforts, they started adding up to make me feel better. Thank you." And as you can see from many, I'm not going to read all of the messages, but they really show that the students on these platforms sort of form this therapeutic alliance with their guide, even though they never see the guide. There's never synchronous communication. It's just written feedback once a week. So there are some challenges and there's some benefits to digital mental health. The challenges are low compliance, although we know in face-to-face therapy, there are also problems with treatment adherence, but the problems are greater in digital mental health interventions. It's not intended for suicidal risk, and a lot of people are afraid to use it with that population because of the implications. Although I'm changing my mind on this now because we had excluded suicidal students, but what you'll find is when you exclude students who have imminent risk when they fill out the baseline survey, suicidal conducts are fluctuating. And so they might not have had it the day they filled out the survey, but then they do have it later on. And these are the students who most need it. And at least we're giving them something. So we have now developed all kinds of strategies, alert strategies for including these students in these programs, but having something a little bit extra for them in case it's needed. They're not for everybody. And most individuals, if you ask them, they think they prefer face-to-face interventions. They'll tell you they prefer to have human interaction, even though once they do it, they're satisfied with the program. The benefits is that it can attract many non-help seeking students that would never receive treatment otherwise, can greatly extend reach. It reduces many of the structural and attitudinal barriers. I want to take care of this by myself. I don't have to travel anywhere. Nobody has to know. Much lower cost in terms of human resources, especially for the self-guided version through which 30% of the depressed students could get well as well. And it can be scaled up to provide interventions to as many students as necessary, decreasing the treatment gap. So just a few little conclusions here. I guess the biggest conclusion is that we were able to predict from baseline which is the optimal treatment for each student and if they're really likely to use a self-guided intervention. I think that's the most important point. We need to keep including greater sample sizes to perfect these prediction models, but I think they're very good for the future. And we also have to think about the students who don't benefit from these. What else can we do for them? So what's next for the World Mental Health College Student Surveys? So many of us have been undertaking these digital mental health interventions, my colleague in South Africa and Australia, in Hong Kong. We've been all using sort of different suites of interventions, but now we want to sort of do an intervention, sort of a very similar suite where we're all using the same sort of toolbox. So we have this new initiative. We've been writing grants like crazy. One of these days we'll get one. But the idea with this new grant is to do an initial telephone or WhatsApp call, a face-to-face, one single session. So they do have that human contact that will increase uptake and include more different digital tools. So we're looking at behavioral activation with text messaging app, a guided DCBT, a remote group cognitive behavioral skills training. And the new thing that we want to do with this is not just use machine learning to look at the optimal treatment, but look at the sequence of treatments. So we know many people don't get better with their first treatment. So the idea is we assign people randomly to one treatment. After 5 weeks, if they don't get better, we switch them to another one. After 5 weeks, they don't get better, we switch them to another one. And we use machine learning to help us predict what would be the optimal sequence of treatments for these students. So just to give you a very quick overview, the single session is a single session. It's based on solution-focused therapy by one of our colleagues that have been working with us, and it's been shown to increase uptake and engagement in different digital interventions. And then we have we're no longer going to use SilverCloud, which is what I showed to you before. That company has been bought by another and they cost a lot of money. And so we're trying to find out, really the idea is here to find tools that are very inexpensive. So it's really realistic that universities can use them. So this is one of my Australian colleagues. He has this program called The Things You Do, where he's found that you can divide all kinds of behaviors into these 5 big groups: meaningful activities, healthy thoughts, goals and plans, healthy routines, and social connections. And there's one session where they help the person develop their own list of activities, and then they just get text messages reminding them to do those activities. And he has some initial evidence to show that this is helpful. And then we're going to do the Uni Wellbeing course. This is also another course from Australia. It's very similar to the Silver Cloud course that I showed you before, all the same CBT strategies. And this is going to be guided on demand, which is, I told you today about unguided and guided. There's this other modality that's called guided on demand, in which the users, when they feel like they need it, they ask for the guidance. And there's a fourth modality, which we haven't explored yet, which is called just in time. And that's basically where you're doing passive data monitoring. You can have things like looking at their sleep patterns, their exercise patterns, and any kind of thing that give you an indication that the person is getting worse. And then you send the guide in once you have the information. That would be the just-in-time modality. And then we're also using, this was a colleague of mine from South Africa. We've actually now started to do it in Mexico and also in Australia. And these are remote group cognitive behavioral skills training, looking especially for the students with social anxiety. These group modalities seem to work very well. And lastly, what we want to do in this consortium, once we're all testing out this whole basket of interventions and we're looking at ways to predict optimal treatments and the sequence of treatments, we want to develop a tool for clinicians and university clinics to assist on their decision-making and treatment assignments so that students can come, they do the same baseline survey that you guys are giving. It goes into this application and it tells the university clinics, this student can benefit from a self-guided, this student would do really well with a group intervention, this student needs some sort of face-to-face care because these other things aren't going to work. And that's our goal in the next few years, if we get funding. And if you want to see any more information about the data that I've showed you from the Yo Puedo Sentirme Bien trial, these are 3 publications which look at the overall effects and the precision medicine effects. I'll give you a minute. And gracias.
Thank you very much. Thank you very much.